Hi there, my name's Felix Humphreys. This is my talk on anterior shoulder dislocation. So the shoulder is one of the most freely movable joints in the body. There's a fine balance here between mobility and stability, so it's inherently unstable due to this. It consists of 4 joints, with the focus being on the glenohumeral joint today and its extreme mobility, which comes at the cost of stability. Glenohumeral dislocations account for 50% of all types of joint dislocations, with 95 to 97% of these being anterior. Here's the objectives of today's talk, and the initial part of this talk is the anatomy of the shoulder. So there's 4 joints: the glenohumeral, the sternoclavicular, the acromioclavicular, and the scapulothoracic. In terms of the bones at the glenohumeral joint, there's the humerus, which is a long bone of the upper arm, and the scapula, which is a flat triangular bone. The scapula is a triangular flat bone which provides attachment for 17 different muscles, and the glenoid is on the image on the right is the part of the scapula that is involved in the glenohumeral joint, and it's a shallow dish-like pear-shaped thickening in the scapula inferior to the acromion and coracoid. The glenoid surfaces have a retroverted orientation of 7 degrees and a cranial inclination of greater than 15 degrees. Now, the joint itself is a multi-axial synovial ball and socket joint from the articulation between the humeral head and the glenoid of the scapula. It has hyaline cartilage, hence it's synovial, and the movements include all that are listed on the image there, on the slide. Important points about the glenohumeral joint. There's a 4-to-1 disproportion between the round head of the humerus and the small, shallow glenoid cavity. So only 25 to 30% of the humeral head actually articulates with the glenoid at any point in time. The labrum is a rim of fibrocartilage around the edge of the glenoid fossa that functions to deepen the cavity and increase the stability of the shoulder joint. It can increase the articular surface by 50%. It also generates a suction effect via negative intra-articular pressure. The capsule itself is a fibrous sheath that encloses the joints. It's thin and loose, contributes relatively little to stability unless at the extremes of motion where it becomes tight. It has rotator cuff tendons and other ligaments fused to it which contribute to stability. Inferiorly, there's no cuff reinforcement, making it weak and a common site for dislocation to occur. Synovial membrane lines the capsule. This image depicts the attachment of the capsule of the shoulder joints attached to the border of the labrum, and the glenoid neck extends superiorly to the coracoid process base, and the humeral side inserts to the anatomical neck around the articular margins and inframedially can delve or dip down to the surgical neck, forming this recess, the axillary recess. The synovial membrane lines the glenoid labrum, the capsule, the articular margin of the head of the humerus, and covers the bare area of the surgical neck within the capsule. It produces synovial fluid which lubricates the joints, and it invests the long head of the biceps tendon in a tubular sleeve as shown in that image there. It can have herniations anteriorly and posteriorly to communicate with the subscapularis and the infraspinatus bursa respectively. So, glenohumeral ligaments. There's the superior, middle, and inferior glenohumeral ligaments. The inferior is the primary restraint to anterior subluxation when the shoulder is abducted to 90 degrees and externally rotated. And the inferior glenohumeral ligament, it's a complex that consists of an anterior band, posterior band, and an intermediate portion. The intermediate portion is important because it can have a herniation between the one of the bursa, meaning it can have joint fluid within it. Inferior is also the primary restraint to anterior subluxation when the shoulder's in that position, so it's the one that usually would be damaged in an anterior dislocation. This forms a hammock as well for the humerus to sit in the normal position. Here's an image demonstrating the arm in an abduction and external rotation. So as you know, you abduct the arm and you externally rotate it, and it can slip forward in this position as a dislocation. The coracoacromial ligament is a triangular ligament from the coracoid process to the acromion. It's superior to the humerus head and serves basically to increase the surface upon which the humerus head is supported, with a subacromial bursa that separates it. It's very strong. If there was enough pressure, the humerus would break before the actual ligament would break itself. Next is the coracohumeral ligament, which is also relevant and present there, but not as strong. Now, the muscles. The rotator cuff is the most important muscles in the joints here. It consists of the supraspinatus, infraspinatus, subscapularis, and the teres minor. The slide here just lists the attachments of them if you wish to read through that. These tendons of these muscles fuse into the capsule of the joint, so it also serves as both static and dynamic stabilizers in that regard. The most important neurovascular structures here is the axillary artery and the two branches it gives off, the anterior and posterior circumflex humeral arteries. And the axillary nerve is the main sort of nerve of the joint that contributes to it. It passes through the quadrangular space to lie immediately inferior to the capsule of the joint. There's four main bursa that can communicate with the joint. Wanted to just mention the key one, the subscapularis bursa here, as it communicates with the joint via the foramen of Waite-Brecht, which is between the superior and middle glenohumeral ligaments. It's relevant because this can be of differing sizes and weaken the capsule, predisposing to instability. Here's just an image demonstrating the foramen of Waite-Brecht. So there's both static and dynamic stabilizers involved in the shoulder joint. The static involve bony articulation, which is minimal stability, the glenoid labrum, the capsule, ligaments, the negative intra-articular pressure from the glenoid labrum, and the suction adhesion effect of this. Dynamic ones, mostly the muscles, rotator cuff, biceps, triceps, periscapular muscles, and pec major, which keep the head center and compress the capsule. There's also that fusion of the tendons with the capsule of the joint, as mentioned before. So basically, out of these stabilizers, the bone's pretty poor, capsule relatively poor, the muscles and ligaments are very effective at stabilizing the shoulder. Anterior dislocation usually results from forced abduction and external rotation. The first injury can lead to high recurrence of a second injury, unfortunately. Statistic, over 80% of patients under 20 years old have recurrence of the anterior dislocation following a primary event. And if there's recurrent dislocation, then disruption of the stabilizers should be suspected. In terms of the diagnosis, you look at the humeral head lie on an X-ray. There's 4 different types of dislocation: subglenoid, subcoracoid, subclavicular, and intrathoracic, as demonstrated on these images here. There's multiple reduction techniques. Here's the old school way, the kosher maneuver, in which you go from external rotation with traction, adduct, and then internally rotate. But this has now been shown to increase the risk of injury from the torque and the pressure. Scapular rotation is known to be, what they say is the best method now, where you just get traction from hanging your arm over a bed and you rotate or manipulate the scapula in the direction that's demonstrated there, and it pops the shoulder back in. Make sure to always document neurovascular status before and after doing this. Here's the Davos technique. I personally prefer this one. Well, I like it because it means the patient gets to control their own traction. They interlock their fingers and lean back, and it means that they're not as tense or anxious about somebody else pulling their shoulder, so they can relax their muscles proportionally a bit more. Now, predisposing factors to shoulder injuries: sports players, previous injuries, damage to the labrum, bone, capsule, or muscles. And this all results in the net force being unbalanced of how the shoulder is sitting in the joint. So, predisposing factors: you can have anatomical variations, glenoid hypoplasia, an anteverted glenoid fossa instead of retroverted. And you can see that ratio there through those lines that are drawn in the angles. If that's more anteverted, then you're more likely to slip forward. An increased glenoid index, which is the height to width ratio, means that the glenoid fossa can be thinner and more likely to dislocate, or a flattened and shallow glenoid bony contour. Humeral containing angle is basically this angle that you can see in that image there. If it's more, less than 64 degrees, then that means that there's a more proportionally bigger head of the humerus to the glenoid fossa, so you're more likely to slip out as well. Also, the coracohumeral interval, there's a 10% increase in instability for every 1 millimeter increase in coracohumeral distance. The key structures at risk here: there's the labrum. From a dislocation, the key structures at risk: the soft tissues, the labrum, you can get Bankart lesions; the capsule, the inferior to anterior glenohumeral ligaments, and the rotator cuff. And the bone, you can have humerus issues, so Hill-Sachs deformities from the humerus, greater tubercle fractures, or a bony Bankart. Nerves, you can get axillary nerve involvement in more than 40% of dislocations. which means that you can't abduct your arm well, and you get the loss of sensation over the patch on the lateral shoulder. And then vessels, you don't often rupture these, but if they do, then it can cause quite a lot of morbidity. Now, these are the sort of key characteristic lesions seen in these dislocations. The Hill-Sachs defect, it's a posterolateral humeral head depression fracture, and the Bankart lesion is an anterior-inferior labral detachment from the glenoid called a bony Bankart when the fracture of the glenoid rim is involved. Here's just some images demonstrating the mechanism. So the shoulder or the humerus head slips forward, as you can see, and then it can go back into the edge of the glenoid fossa, causing that dent or depression. See that Hill-Sachs on the image. That's a Bankart lesion, which just involves the labrum being torn, as you can see there. And a bony Bankart is when there's also a fracture as well of the glenoid fossa. So, importance of these lesions. The glenoid labrum increases the glenoid surface vertically by 75 degrees and horizontally by 57 degrees. Studies have depicted upwards of 87% of anterior dislocations having an associated Bankart lesion. This can reduce the labrum height by 50%. Bone involvement causes further increase in the reduction of height. This leads to normal loss of mechanism, so you lose that chock block effect of the labrum, you lose the compression mechanism of the rotator cuff, you lose the function of the inferior glenohumeral ligaments, and you get reduction of the glenoid articular arc. Here's the image, the chock block effect. You can see the normal sort of effect of it in the image on the bottom left, and then in the center how you can dislocate. And if that causes image, then you're more prone to further dislocations, as shown by the bottom right image, as there's less chock block effect. So another complication that's not as often talked about is the effect on proprioception of your shoulder. So there's Ruffini and Pacini corpuscles that are distributed throughout the capsulo-ligamentous complex here. These generate proprioceptive feedback to cortical systems, so your brain, which then responds to coordinate your muscle activity to keep the humeral head center on the glenoid fossa. And this has constantly been adjusted, but we do it subconsciously. The afferent nerve endings can actually be damaged during a dislocation, and this means that there's delayed proprioceptive signaling ongoing from this, meaning there's more instability through uncoordinated muscle response, causing that misaligned joint reaction force. In a Bankart lesion, the more severe and extensive the capsular labral injury is, the greater the disturbance of the proprioceptive joint mechanism. In summary, primary dislocation leads to greatly increased risk of recurrent dislocation. Dislocation equals damage to stabilizers, equals increased stability, which then causes a higher risk of dislocation, and so on. So, surgical management of this. Arthroscopy is effective to repair labral tears, but not really for bony injuries. In above 80% of cases of recurrent dislocation, there is bony involvement. So in a bony Bankart lesion, patients with 17 to 30% of glenoid bone loss will need an open procedure. A lattice J is an example of this. This involves fixing the horizontal limb of the coracoid process to the antero-inferior margin of the glenoid with a screw, and also excising the pectoralis minor, coracoacromial, and coracohumeral ligaments. But they preserve the coracobrachialis, the short head of the biceps tendon, and some of the coracoacromial ligament too. Here's an image demonstrating the lattice J. So you cut off the coracoid process, you screw it to the side of the glenoid fossa, and that creates an increased depth, basically replaces where that fracture would have been so that you get more stability of the shoulder. Here's an image showing that it's the coracoid process inserted through a slit in the subscapular muscle and attached adjacent to the glenoid fossa. There's pretty good excellent clinical outcomes in reducing the rates of anterior dislocation. So you get increased glenoid arc, you get the conjoint tendon acting as a sling to the inferior subscapularis and capsule, and the capsular effect, so the inferior capsule is reinforced with a portion of the coracoacromial ligament from this. Cons though, complication rates of surgery are high, 16%. You can get reduction in range of motion, higher rate of arthritis following this, some nerve injuries, iatrogenic injuries, instability, and non-union is things to be wary of. So in conclusion, anterior dislocation of the glenohumeral joint is the most common type of dislocation. It can lead to injury of the stabilizers, increasing the risk greatly for recurrence of dislocation, and the latter J is a procedure that can help to restore the damage resulting from anterior dislocation and reduce the rate of the risk of recurrent dislocation. Thank you very much for my talk. Hope you learned something. Till next time. Cheers.